Hello and welcome to Interventional Mindset. This is Nate Radcliffe and I'm here with Deb Ristvedt. How did I do?
Really good. It's a hard one.
Okay. And we were talking, you're with Vance Thompson Vision in Alexandria, Minnesota.
Yes,
Okay.
that's correct.
All right. And so, we're always interested in hearing from each other stories of adapting new technologies and becoming more interventionalists. And I wanted to hear a little bit about your experience. I understand that you've had some success with even standalone Omni. And I consider those procedures perhaps some of the toughest because, we're used to giving the sweet candy of cataract surgery and throwing MIGS along with it. But when it comes to doing standalone MIGS, a lot of us don't quite have the confidence to make that recommendation. So I'd love to hear about your story, how you got involved with MIGS and sort of how things evolved for you as a surgeon.
Yeah, so I graduated from residency in 2011. So as a comprehensive ophthalmologist in a smaller town, I joined a third generation practice where we were doing everything. And I even saw my dad do, a scleral buckle at one point. And so when I came back to Alexandria, there was just this great need for glaucoma care. And as I was taking over patients from my dad, the whole MIGS came up. So that was kind of at the time where they were introducing minimally invasive glaucoma surgery. And I was so excited about it because, in my mind, what if we could intervene a little earlier in the disease process? What if we could get that pressure to a more stable level so that we don't have to be as invasive and risk more complications, from more of our invasive surgeries? And so I really dove into it pretty quickly. It started with the eye stent and just kind of evolved from there. And I think that's one of the biggest things that gave me confidence. I just kind of dove right in and I said, this makes sense to me as a surgeon. As a cataract surgeon, you go through steps and you continue to evolve your technique and get better. And I feel like that's kind of been the MIGS space for me. I've just built on top of each procedure. And the main thing was really having the confidence in the angle, identifying the trabecular meshwork, knowing where you were going, and being able to, do two-handed surgery, one with the gonio lens and one with the, instrument itself. But what I was finding was patients were really recovering quickly. And so it's kind of a minimally disruptive, kind of technology that we're dealing with. And so when the Omni came to be, I was so excited that we had another technology in the angle to use that now could be used as standalone. So many of these patients are pseudophakic, and you always question, oh, did I miss the boat? And at that time, they didn't have, MIGS technology. But this is a great way to really try to revitalize that natural outflow pathway, even after they've had cataract surgery. And as I really gained confidence in that, I found that it was a pretty natural conversation because they knew what cataract surgery was all about. And so I was able to compare cataract surgery to this surgery, saying the Omni surgery is, about the same time as cataract surgery. We use the same sedation as cataract surgery, and the recovery is about the same time as well. And, when we talk about evolving, to be able to incorporate even ocular surface disease into your glaucoma care and say, with something like the Omni, we could maybe get you off a drop or maybe 2 drops if it's really successful. And they're excited about that because their eyes don't feel good. They have fluctuating vision. And so it's really fun to be able to really be incorporating all these technologies together so that they have comfort, they have better vision and stable pressures.
Okay, there's a lot of things you said there that I loved hearing, and that I just want to recap on. So this concept that we're having almost a renaissance of the sort of old school, if you will, comprehensive ophthalmologist, because you're right, 20, 30 years ago, ophthalmologists did everything from buckles to PKs, and of course, cataract surgery and strabismus surgery. And I feel like we're in a moment where ophthalmologists are finally bringing together the newer fields, dry eye, advanced cataract surgery, and glaucoma in this interventional way that maybe a generation ago was sort of, it was mostly a lot of cataract surgeons, but not as much of the old school comprehensive surgeon. I love how you tie your recommendation to something the patient's familiar with, like the cataract surgery. And I agree with you that we have so many pseudophakic patients in our practices that are just crying for help. They're on 3 drops, their eyes are red, and they're ripe for a number of interventions, certainly Omni, but Zen, Durista, even SLT laser, all that population to me is like the golden population that we can really help and who, really have better things to do than, be taking drops all day long.
Right.
And then, am I right that you have also taken a little bit of turns into the other areas, dry eye and refractive cataract surgery as well? Tell me about the rest of your practice.
Yeah. So, when I first started, it was very much traditional cataract surgery. And as the technology has evolved, and as I really took that leap to invest in better technology, I gained more confidence in the outcomes. And so I think when you're getting started with anything like refractive cataract surgery, it's about, do I have the right technology to treat this patient? Can I get them to the goal line after surgery? If I don't do refractive surgery, do I have someone that maybe could do a laser fine tune if they needed some adjustment after cataract surgery? And so as I began to acquire different technologies in the office, in the operating room itself, and had partners that could do any type of laser fine tune for me, I felt like it gave me the confidence to really talk to that patient about what premium technology does and what they could be seeing, without glasses or without astigmatism. And so, I think that's the biggest thing, is really seeing, okay, what do I need in the office to prepare me to get this patient to a happy place? And then as far as dry eye goes, that totally evolved in my practice. I used to run from dry eye because it took time, but now we have such amazing things in the dry eye space to treat meibomian gland dysfunction. We have great drops that, are coming down in price. And so we have that, that the patients really enjoy. And we have things that can be put in other spaces too, as far as, the punctum, if they have a lot of inflammation. And so the way that, all the drugs are, evolving, all the technology is evolving, for all of our patients, who come in for refractive cataract surgery, you want a pristine ocular surface. For all our glaucoma patients, you want a good ocular surface. They're going to do better and they're going to be more happy. And so it's all just fitting together just beautifully. And I love that we have so many options now.
I couldn't have said it better myself. I agree with you, and it does all come together. And it's really nice to see too, when it comes all together in one ophthalmologist. I think you really have the interventional mindset that we're really celebrating here with this project. And I'll thank you for talking to me. And I can promise you we'll be back in touch because we want to hear more about how things are going for you and your practice over time.
Thank you.
All right. Thank you very much.